Hey everybody, you are listening to The Poison Lab, a show about poisoning from people who manage poisoning. I'm your host, clinical toxicologist and emergency medicine pharmacist Ryan. And today we have another rendition of Toxicologists versus the Internet with a really great guest, Dr. Frank Paloucek, PharmD DABAT. Many of you out there in the poisonverse might know of Frank. He was one of the original EM pharmacists, and he was one of the very early cohorts of diplomates of the American Board of Applied Toxicology. His impact on the pharmacy profession is pretty profound, so a lot of us know him. He is currently a proudly retired professor emeritus of clinical sciences at UIC, where he spent nearly 20 years as a pharmacy educator and the director of their PGY1 residency program. He remains a consultant for the Illinois Poison Center and was integral in the Toxikon Medical Toxicology Fellowship and trained many of the people who are even on this show, like Dr. Jillian Theobald. And he's the co-author of the textbook Poisoning and Toxicology Handbook, 4th edition. Most notably about Frank, he's mastered the use of colorful language, we'll say, through years of practice. So listener discretion advised in this one, as there's some adult words used. But it's nothing you wouldn't hear in passing in the emergency department hallways. And as expected, we have an absolute blast on this episode. We start off hearing about Frank's history and how he got into toxicology. If you want to hear what it's like practicing in the emergency department in the 1980s, when emergency medicine attendings weren't actually a thing in a lot of places, it's a really fascinating history. Then we have a little fun myth-busting, some toxicology truths, as Frank likes to call them. Truths, or at least supposed truths, that when you examine the literature might actually be myths. We talk about things like, do you need BAL before giving calcium disodium edetate in severe lead poisoning? And a variety of other fun topics. Then we go on to do some Stump the Toxicologist like we normally do, and I am proud to say that I was stumped. If you're like me and you don't have a great toxic differential for a penile lesion, you'll get one after this show. Finally, instead of answering drug-related questions from the internet like we normally do in this type of episode, Frank and I end up managing a case of poisoned AI. We asked ChatGPT to pretend to be a poisoned patient, but not tell us what the poison is. We get to ask it for lab values and imaging and symptoms, and it's pretty fun trying to sleuth out what is going on. We eventually identify the poison, and it's a lot of fun, but really, I think it's a glimpse into what the future of toxicology training could be, using high-fidelity toxicology patient simulations with the help of artificial intelligence. Maybe it's something you could bring to your own training program if you're out there helping train the future toxicologist. As you can tell, we're going to cover a lot of interesting topics on this episode, but if you are one of my high-yield friends listening on 1.5 speed, you can jump to minute 30 to go right into the cases. Okay, almost time for the show. But first, our standard disclaimers. We're going to be talking about real fatalities, and while this allows us to discuss a lot of great learning points, some of these were intentional fatalities. If you or a loved one are struggling with thoughts of suicide, someone's there to listen. 1-800-273-8255 is the National Suicide Prevention Lifeline. Please call. Finally, even though we're going to be discussing medical management, treatment, and diagnosis, this podcast is intended for educational purposes only, and we are not providing medical advice. If you think you're being poisoned or you have a general healthcare question, call your primary care provider or reach out to your local poison center at 1-800-222-1222. Now, without further ado, let's get on with the show. Hey everybody, you are listening to The Poison Lab. I'm your host, clinical toxicologist and emergency medicine pharmacist Ryan, and we have a doozy of a show today. We have a guest on, one of the, I think, founders of EM pharmacy. He's also one of the earliest ABATs, none other than Frank Paloucek with us today. Thank you so much for joining the show today.
My pleasure, Ryan, but I hope you know what you got yourself into here.
Oh, I very much do. Many of you have probably heard of or read something that he's written or heard his rantings on some email chain. I more recently got to hang out with you at not only ASHP midyear, but also the first ever EM Pharmacist Conference, which was in Austin, Texas this year. That was a lot of fun. What did you think of the conference?
Oh, I liked the conference. I really loved what was done with the virtual one the first time. I have not historically, and to my great chagrin and regret, I was immature and stupid. I wasn't as social or involved with any pharmacy community or the professional communities for a long time. I have a deep problem with bureaucracy and stupidity and guidelines and people telling me how I'm supposed to do things. And that's how people usually know me, because I'm ranting about something being stupid. And I regret it, because I could have learned from the other people. I had a blast. I learned things I didn't know. You can never stop learning when it comes to tox or EM, because our literature sucks. And people were very responsive to it. And I think that somewhere along the way, where I came from back in the old days, a lot of the teaching was abusive and awful. A lot of the behavior was not courteous. And yet at the same time, there seemed to be a lot more transparency to how people thought about you. And you weren't really sure if they were being nice. And I learned to be I'm told I'm very blunt or frank. And in that regard, maybe that's true. And people responded to it. It's just that I'm acting different sometimes, I think. I don't know that I always make sense.
Well, you make a lot of sense to a lot of people, I think. And I appreciate you being on the show with us. This is a show about toxicology, and you were one of the early tox, ABAT, probably in one of the original, the first starting classes of people who have passed the ABAT exam. A lot of pharmacists are interested in the American Board of Applied Toxicology. Can you tell me a little bit about your background and your history with Illinois Poison Center, how you kind of got into this? We're going to dive in. We're going to do our normal stuff, listeners. We're going to do some cases. But for right now, I want to hear a little bit more about Frank. So can you tell me how you actually got into this whole field in the first place?
Oh, gosh. I was a bachelor's pharmacist, not a PharmD. It was kind of a relatively burgeoning field at the time to get your PharmD. And I just wanted to be a community chain, independent pharmacist. I was working in a pharmacy. And then they offered me this great job, and it wasn't that great. It sucked. And they thought they were being wonderful. I wanted to do more. I got my PharmD, and I had a drug information rotation while I was trying to get out of one of those hospital rotations, because that just sounded awful. And I liked it a lot. I was getting all kinds of questions from people who I had been indoctrinated culturally to believe knew everything, like physicians and teachers. And I started writing. I realized the questions I was being asked were being used as people's lectures in the College of Pharmacy. And I thought, that's bull. I'm writing that lecture. I'm doing the work. I'm not getting paid for it. What the hell? And so I got my PharmD in Philadelphia. There was a physician there, Gary Cuppett, whose gigantic influence on myself, on Ruddy Rose, on other people that were at Philadelphia and trained there and got involved with Fred Henretic and Tony Temple, who were very early researchers with Tylenol. And it just sounded fascinating. But I didn't see it as a career. I came back to University of Illinois to do research, phase 1 clinical research, and I did a fellowship. And I had to start with doing a residency, and it required me being on call in the emergency department. And here's where I really started answering your question. The emergency department of the University of Illinois in 1984 had no attending physicians. The Department of Medicine and Surgery thought this emergency medicine stuff is garbage, and we don't need specialists in that because our residents know how to handle these cases. And so the ED had a physician who was a colleague of mine for many years, Gerald Leiken. And Jerry would come in Monday through Friday as a Department of Surgery faculty member and sign off on charts from the entire day before.
Wow. That's the same Gerald Leiken that is the co-author of the textbook you wrote.
Yes. And he was going to figure prominently in this early. And I'm old, so you're getting a lot of story here. You're going to have to do some editing. So the emergency department was staffed during the day by a pharmacist Monday through Friday. And we actually had a SIVA QST machine, which was an enzyme-linked drug machine, and we had reagents, and we would be given blood by a nurse or a physician, or draw our own blood as pharmacists, spin it down, put it in let it coagulate, spin it down, draw it up, put it in the machine, and then we could run on the spot within an hour, give you a result, drug levels for theophylline, which was huge back then, phenobarb, phenytoin, acetaminophen, and aspirin. Those were big things for us back then, several of which are still very big things now. And then at 5:00 at night, the pharmacist would go home, and really the name you might know is Michelle Zell-Cantor, because she was my emergency department preceptor. Michelle would go home, and then the pharmacy residents would come in at 5:00 and staff the ED for the remainder of that night until 8:00 the next morning. And then we had 24-hour shifts on the weekend. And we were there along with the medicine side, had an R3, 2 R2s, and a bunch of interns. The surgery side had an R3, 2 R2s, and interns. And that was it. All patient care, weekends, nights, overnights, all was just us. And so when you say, how did I get in there? Well, the EM residents, the trainees, they weren't EM, that were in that department said, okay, you guys do the theophylline levels. Asthma's kind of protocolized. All we do is theophylline, because that's all we had to worry about, because we didn't have meter-dose inhalers and occasional shots of epi. You take care of the asthma patients, and you do the phenytoin and phenobarb. You take care of the seizure patients, because really, there isn't a whole lot else to do with them. And you got to handle the overdoses. We don't know anything about the damn drugs. You take care of those. And I was, and my fellow residents and the people we trained, I helped train afterwards, we were in essence physician extenders, physician assistants. We were what pharmacy, many people accuse pharmacists of who did the PharmD wanted to be. They wanted to be MD wannabes and just got off on it. And I did not get off on it. There was a lot of that job that was kind of stupid and dumb. Mm-hmm. And there's nothing like being woken up at 2:00 in the morning to run a theophylline sample on an asthmatic that has to have a minor surgical procedure done, but they have to have a good level before they can do the procedure. And it's just, it's so, I don't want to be a tech. And that we had a lot of tech. Anyway,
it sounds
first
fun.
year, it was a blast, Ryan. We knew how to draw blood. We drew from A lines from ICU patients. We were certified for a lot of things that a hospital would get a JACO score, or whatever I'm supposed to call the stupid thing now. So we kept records, our own shadow chart. And there was a patient in my 1 year of residency with on-call that presented to the emergency department 67 times. And every ED has a frequent flyer. And this guy was your classic drunk, maybe mid-30s, looked like he was 82. He came in a third of the time as theophylline or as phenobarb, or both were over 30. A third of the time they were both 0. And every now and then one of them was therapeutic and the other one, who knows. Well, he came in once and he had a phenobarb of 126 and a phenytoin of 130 or something. Ooh. And we wrote him up. We dialyzed him. We wrote him up. We wrote him up 2 more times in the next 3 years. I think he holds a record for somebody being the patient discussed at an NACCT meeting.
Wow.
On posters. But Jerry said, "Oh, let's do this." And I'm like, "Oh, come on." And he said, "Let's do it." And so I went to the, it was the North American Congress of Clinical Toxicology, an ACCT meeting in Baltimore, and there was 400 people there, maybe. I'm standing at this poster, and you name the name, and they came up and were the most polite and nice people. And then Jerry would turn to my side, and if you know him, you know exactly what he did. He smacked me upside the arm, and he would go, "You know who that was, like, right?" And I'd go, like, "No, that's Louis Goldfrank." And all these people are talking to me, and I was like, "This is really cool." And nobody knew who anybody else was in terms of job. And that sold me on tox. That was how I got into tox. I went, this is so damn cool. Now, I actually didn't take an EM or a tox job because there weren't any at the time. And I was in internal medicine for 2 years. And then Michelle, and she left and went to county, which was when Toxikon started in like about 89. And I started part-timing in the ED. I went there full-time. I started an EM tox residency fellowship program, ran it for 10 years. I got downsized. There was a bad stock market crisis, and I couldn't justify my job because I didn't document anything. And they said, well, he doesn't do anything. Well, everybody loves him. They all want him. Well, there's no records that he's ever there. And I ran a residency program at U of I for 20 years then, and just stayed involved as best I could. And I think the reason I stuck with it all is that there's so much that can be done with very basic skills. I often hear the medical residents talk all the time. Really, the art of clinical toxicology is a supportive care, but it's actually basic pharmacology, basic pharmacokinetics, basic thinking skills are really, really important. And we don't teach those at all well anymore, in my old man grumpy opinion.
You bring up a lot of things that one of my colleagues, another ABAT, Matt Stanton, he files IVents for everything he does, and I don't because I'm lazy and I just like to do things cognitively. And he says, well, it's really nice when you're at a meeting and you could show your manager all these things you've been doing. And I was like, my manager never asks me. They don't.
Ryan,
but one day
I would advise you
find
a way. I really would. I regret it. But then I found out what made me more good than bad, the risk benefit analysis for me to be decent in tox and EM. Most of the same skills transferred into running a residency program extremely well, which is managing people who don't want to do what you want done and getting them to do it, making them think it was their idea. Yeah,
that's great. Well, that's a storied and really fun ride to the career, and you clearly made a big impact on a lot of people. I work with Jill Theobald, Dr. Theobald, and she talks about your impact on the Toxikon training program all the time. And I believe you have something that you've coined called truths.
Yes,
truths that are actually
they're toxicology truths that are really myths when you look at the foundational literature.
You got any examples of truths we can?
Oh, well, the whole argument about charcoal, there's no data to support charcoal decontamination with clinical outcomes. That's crap. There's no, it's all, the fact that the Scandinavian method that people forget about, that included ICUs, developing ICUs and intubating people and lavaging them. Also, all those patients had charcoal, and that improved mortality from barbiturate overdoses. Oh, I didn't know barbs were dangerous. Oh, come on, they can't be. And I'm going to stop. But that's one. Another one, this is one that drives me nuts, and I don't get off my ass and write it up. There's some common themes. And one would be you have to give BAL before you do EDTA. That's garbage.
Can you drop the BAL calcium? Because guess what? BAL, truth or not, BAL is gone forever.
I know.
So no one's going to use that anyways. What was your thoughts on using BAL before calcium disodium edetate?
Well, if you go back and you look at Chisholm's stuff, all the stuff that modern lead therapy is based on, I'll do this quickly.
Wait. I got to interrupt. I'm sorry. So for the listeners, in case we've been on a little bit of a tangent here, what we're talking about right now is there is a suggestion that if you're going to use calcium disodium edetate, which is a chelator that we use for a lot of things, but severe lead poisoning is one of them. If you give calcium disodium edetate, which is IV, you're going to pull all the lead out of someone's bones, and then it's going to redistribute because you have a huge body burden in the bones, and now you're putting it into the blood, and now you're going to potentially deliver more lead from the blood to the brain. So you'll find it written, you have to give BAL 4 hours before giving calcium disodium edetate. BAL is another chelator. You give it IM, really painful, deep injection. If you want to know more, listen to episode 2 of the Poison Lab, the other problem with bullets. We talk about the chelators. But basically, you have to give BAL 4 hours before to bind up any of the lead that calcium disodium edetate brings. Frank says,
garbage.
Okay, garbage. Now we're talking about Chisholm Clinic. Go.
All that stuff was from a series. Okay, in my clinic here in Baltimore, he would take a group of children seen over months. He would put a protocol on them. There were no IRBs. And then he would do a different series of studies with a different set of children in the next few months. And then he would do historical controls between these two groups that weren't controlled in any manner. None. Easy to look up and find as long as you can get to 1950s papers in old, which I've done because it drove me nuts. Now, he showed that the same thing happened with BAL and EDTA when used alone. And he then one day said, I give them together and I gave the BAL first.
Clearly,
what's missing here?
Must be
Brian?
protocol now. Forever.
No, there was no protocol. There was no comparator. There was nothing. And then it was supported strongly by some animal studies that were done in rats around 1984 by the lead author's last name was hyphenated, Corey-Schlechter. And a very, very commonly referenced paper. And the problem with that paper, and Jillian will be happy to tell you how she did some of the legwork on this. The problem with that paper is that they dosed these animals and then they gave them chronic lead from their feed over a month. And then they would dose them with drug and then sacrifice them and analyze tissue samples. Now, I'm going to get complicated here, and I don't know how well it'll work orally. But they found that in that study that in one of the treatment groups at one time point, the brain concentrations went up, which supported what you kind of alluded to before, this concept that I give a chelator, I get rid of a whole bunch of drug from the blood, and then it rushes in from everywhere else, and then it goes to the brain and it causes rebound encephalopathy is what is a term people use. Yeah. The thing was in that rat study, they took brain and they put it into like an incinerator and fried it and did the ash concentrations, all right? There's a flaw. That method's no longer allowed because it didn't account for blood that was in the brain.
Oh.
And we're getting both blood and brain. You already know the blood concentration was substantially higher, even though it's a much smaller amount of tissue, but you just chelated a whole lot into the blood.
That's a great point. That's a very important point.
That's your Dr. Theobald. Now here, fundamental pharmacokinetics. This is totally wrong. If you look at radio-labeled lead studies, the amount of lead in the brain is in the order of 1,000th at highest, 1,000th of blood. And it's in equilibrium with blood. They're not the same concentration. It's not passive infusion. Now, I suddenly clear the blood. Chelator worked 100% perfect. There's nothing in the blood. Concentration gradients would say it's got to come out of those organs and go into the blood until it reequilibrates. What organs will empty the fastest and start to raise the concentration in the blood? The ones that get the most blood flow. Now, does your bone get a substantially larger amount of blood flow than the brain?
I'm going to say no.
Of course not. There's a lot of storage site there, but it takes time to pull much out. Well, in essence, when I pull out of the major target organs drug to reestablish a new equilibrium concentration then you would think that at best I'm going to have less drug in the whole system because I got rid of some, and there'll be less in every site, and I might actually clean out the more highly perfused sites first. Well, how do you explain the symptoms? And then I go, have you ever guaranteed in these studies that there was no more lead in the gut from these acute kids that he was treating that full of goddamn paint? And the answer to that would be no, Ryan. I'll go to my grave thinking, because I can't prove and we don't have the studies to confirm or deny, that might be what's happening there.
This is why we actually have so many debates within toxicology, because we have such limited literature, and when you really examine it, sometimes it's very flawed, yet we have such dogma and doctrine that stems from it. So it's wonderful to push back and hear, well, hey, actually, that's more of a truth than it is a truth. And I'm really appreciative to have you on the show and showcase some of those examples.
We may not even get your damn cases. You keep me
That's
going.
Okay. No, this was wonderful. All right. Any listeners, if you want to challenge, feel free to, record your rebuttal and send it in. And what? I also want to bring up, I really appreciate, I have never found a single person who had a bachelor's in pharmacy and then went on to get their doctorate in pharmacy. There's always a degree of critical thinking that they display, because this was before the time when PharmD was just the entry level. Everybody gets this degree to get into the field. You check your boxes and then you're in. There are a certain cohort now where the PharmD is just something to get through so they can get to their job. So I feel like the group where the PharmD was really an extra step. It was an extra piece that wasn't needed. It was only for those who really wanted to get down into the underlying whys who really went for that. I feel like it's people who really put the title of doctorate to work. So I'm thrilled to have you on the show. I love getting to hear about this. And Thanks for taking us down that historical lane. You've definitely seen a lot. And, covering all the way back to the Baltimore lead clinics. And I know you've remained active in talks, dealing with our TikTok, trends that we have now.
Stupid TikTok challenges. I guess the new one now is Bird Box, where people blindfold themselves and then see if they can drive down the street or ride a bike, or just don't do talk stupid with TikTok challenges.
That's thoughts are the most prolific poison. So that's that is a bad one.
TikTok talks or talks. Anyway.
Yeah, we actually studied after the Benadryl challenge. We did an NPDS study of diphenhydramine overdoses, and we saw more severe outcomes in the adolescent patients afterwards because they were taking whole bottles. Unfortunately, someone just died. A 13-year-old just died of doing the diphenhydramine challenge.
Oh, I missed that too.
It's really sad. So still serious toxicities are occurring from this kind of stuff. Speaking of, this is a little off topic, but some interesting tox news, right? We have the TikTok trends. That's always in the news. They just, the person who was potentially responsible, I'll say, for the Tylenol cyanide murders, just died. I just kind of learned about this person. I knew about the murders, but this person wrote into Procter and Gamble that he was the one lacing the pills with cyanide and was arrested on extortion charges, but they never arrested him because he was requesting Procter and Gamble give him $1 million or he'd keep lacing the tablets, but they never were able to prove that he did it. I don't know if that made any rounds in the Chicago community.
Oh yeah. There was quite a Twitter and email exchange amongst us about it. And I had to clarify once again that I was in school in Philadelphia with well-documented attendance and employment at healthcare institutions at the weekend of the murders. And in no way, shape, or form could I have been involved with anything to do with that. I'm not the only person they accuse it, but certainly old-time tox people tend to get looked at askance when somebody close to them dies.
That is
wise to do that, I think.
Yeah. Those with the knowledge. All right. I don't know if we can digress any further. We have to get to the cases now. So, okay, for the listeners, if you're interested in talks, as Frank has demonstrated, there are many avenues there. If you're a critical thinker, if you like to learn what answers are, not be told what they are, this might be the place for you. And there is no better example of that than Dr. Frank Paloucek, Professor Emeritus. So we're gonna jump into now doing some cases. So this is just some case learning, and you heard the blurb in the beginning of the show. We're gonna be talking about real cases of poisoning. We're not making light of any serious toxicities that have happened to people, but they do happen, and oftentimes we are called upon to make them better. So the purpose of this is so that we can help understand or walk through the thought process of somebody who gets called about poisonings, what they would think about when they encounter a patient who has these constellation of symptoms. So you yourself, the listener, can also test your mettle, see if you get right what's going on. And it's just a fun venue for us to wax theoretical about toxicologic subjects. So the only rules: you cannot give away what the poison is, obviously. So if there's an antidote, that would be really clear, like, if this is, one specific antidote for one specific poison, just try to censor that. Otherwise, go for it. And we can, give as much information as you think would be relevant without giving away what it is. How would you like to kick this up? Would you want to throw a case at me, or would you like me to give?
I'm a creature of chaos, Ryan. You could roll a dice if you want, or flip a coin. I don't care. What's the normal? What is there a normal sequencing your other guests?
There really is not. I like to give. All right, here's the chaos. Yeah. Pick a number between 1 and 10. I'm holding one behind my back.
Yeah.
Oh wait, now
that's 5 then. I don't want to be difficult, but
actually you have to pick a number between 0 and 10.
0 and 10, 7.
Okay, if it was greater than 5, I was going to go first. So, all right, and you have no way to prove that, but this sounds.
I'll accept it. Let's have it.
All right, so I'm going to give you a case. You know what? This is going to be the easiest case that you've ever. And you know what? It's okay. I know you're going to get this immediately, but it's something I want to talk about anyways.
Okay.
I'm going to just ease you in. So, a 31-year-old male presented to the emergency department with sudden onset hematemesis that started about an hour ago. For listeners not familiar, that means vomiting blood. Physical exam and vital signs were completely normal. So heart rate, blood pressure, everything looked good. Nothing wild on physical exam like clonus or, people's are all normal. Everything's normal, except his venous IV sites are oozing after they place them. So he's got blood trickling down from there. Laboratory and diagnostic findings, we have a hemoglobin of 18. An INR was immeasurably high. His urine drug screen.
I mean, I didn't need it, but okay, that I'm done. I'm done. Do you want to go on, or should I say I'm done?
Well, okay. Well,
right.
Would you like to venture, or at least give some differential here on what you're?
Well, sure. Now, when you first started with 31-year-old and hematemesis, only because I like to, we frequently teach something called toxidromes, and in my group at Toxikon, we like to categorize them as poisontations. A poison presentation, where you include the setting along with symptoms, because there are certain things that when you have a 4-year-old who's suddenly found down by the garage during spring cleanup, there are just things that boom, boom, boom. You're going to say gardening products or car products. What's dad doing at the time? He's being a dumbass or something like that. All right. But here I had a 31-year-old, and you said hematemesis, and I think you said male. I mean, that's important, although it makes me stop thinking of a female in iron, which used to be something I was deeply afraid of because we saw it all the time. And then you gave me normal vital signs, and I'm thinking, well, if it's a caustic, they're already puking blood. They ought to have some tachycardia from some pain and crap. And then you said the hemoglobin's 18. So, it's up. And then you said the INR is immeasurably high. So it's the right age for substance abuse. We're in the Midwest. We've had periodic excursions with weed that has been contaminated because of garbage on the internet about the, enzyme inhibitors that can prolong the activity of CBD or weed and stuff like that. So this is going to be a cannabinoid, and it's been contaminated, and I've got a brodifacoum or some type of.
Hi everyone, Toxo here. No, that was not your internet connection. The internet just can't process all of Frank's musings, and it sometimes breaks down a bit. You will hear that once or twice on the show. Just a warning.
So you think some sort of cannabinoid contaminated with brodifacoum, you said?
Yeah.
Correct. Okay.
Yes.
Brodifacoum, for the listeners, I assume most of you will know this, but that is a super long-acting rat poison that it's a super warfarin. Frank doesn't think that this patient took a bottle of warfarin. He thinks that they may have been using a cannabinoid that was contaminated with brodifacoum. So, okay, here's the rest of the case. Patient had a urine drug screen that was negative. Huzzah! Frank's shaking his head. Of course, it's negative. CT abdomen suggested for perirenal hemorrhage. He was admitted to the hospital, started on vitamin K. INR remained unmeasurably high. That evening, he became altered. Sodium was 125. CT of head showed a large frontal parietal hemorrhage with midline shift and herniation. Reversed with some 4-factor and declared brain dead a couple days later via perfusion study and taken for organ donation.
You conveniently left out his past medical history.
He had no past medical history other than he likes to party. There was I'll give you a second to lock in your fine. Does any of this change anything?
Well, I'm gonna go with no. It doesn't.
Fair enough. So the cause of death: hemorrhagic complications of acute brodifacoum intoxication. Blood brodifacoum level 96.5 mic per liter. And he had a history of using synthetic cannabinoids 2 days prior to this presentation with his friends, which you might have picked up and if in the emergency department if you asked the patient, but who knows if they would have asked in the beginning. So absolutely, this was a case of synthetic cannabinoids contaminated with brodifacoum leading to severe INR elevation and intracranial hemorrhage. Something I know you guys in Chicago got slammed with. We had a ton of it. We're about 90 miles north of you. I don't know if it's exactly 90, but we had a ton of it too. I saw this in the emergency department all the time. Patients coming in. Usually the most common complaint was it was a young male or a young female who just suddenly started urinating blood. And then they would come into the hospital and have an INR greater than 10. And then I would get to go in their room and be like, so what synthetic cannabinoid were you using recently? I heard a lot about Green Giant. That was one of them. But there was tons of different ones that were actually used. I don't know what your experience was, but it was a pretty harrowing experience trying to get these people get their INR down afterwards. So we would start these people on 50 milligrams 3 times a day, sometimes, of vitamin K, which for the listeners, if you're not familiar, that's like 150 times the normal dose. You might put someone on you might urgently reverse someone with 10 milligrams IV, or putting people on 150 milligrams a day. Hard to get.
Oh, God, yeah. It was a hassle.
I think Renee Gimbar, the ED pharmacist at UIC, and Joanne Rutsolias, I think is how you say it, at Cook County.
At Stroger Hospital.
We're really involved in actually figuring out how to get enough vitamin K for this outbreak.
Yeah, very involved. And Michelle at the pharmacy involvement at trying to create some kind of some organized collection, storage, inventory was very key. Yeah, it was horrible. It was horrible. People don't understand how it was a horrible summer for the Tox fellows. They were out collecting samples and doing interviews. They worked their asses off that year because of that. Yeah.
That's unbelievable. Well, and it's a tough patient population sometimes to get to these brodifacoum. You can have people with an INR greater than 10 for months to a year after this. I think the half-life is 45 days in whatever, in one random person they measured it in. And so trying to get people to take vitamin K consistently for a year, or however long you have to do, you have to have, case management follow up with these patients.
Plus convince them that evil had been done to their good stuff,
Right. Yeah. Which, thank goodness, I really feel like synthetic cannabinoids like K2 and spice have fallen out of use a little bit. Probably due to legalization of actual marijuana, which I will happily have some oh my goodness, from a drug safety standpoint, is THC 1,000 times safer than these random chemicals people are smoking so they don't test positive on a urine drug screen, which, like this case, this patient didn't test positive for any THC because what they were smoking was nothing like THC. It might actually hit a CB receptor, but it's a full agonist there, and it has 800 times the potency as opposed to THC, which is a partial agonist and lasts a tenth as long. It's just wild. What still baffles me to this day is, how did the brodifacoum get in there? It continues to pop up. There was just an outbreak in Florida, and there was an outbreak in Europe this year.
Yeah, I saw the Europe one. I didn't hear about the Florida. Well, I do think, when it first happened, I got on. Now, I'm not a skilled internet surfer, but there were chat boards 4 or 5 months before the outbreak in Chicago that were in India, where people were talking about mixing brodifacoum because of the drug interaction with the CYP enzymes, and that people should do that. And I wonder if that information in some manner is still out there on Reddit or Arrowhead or somewhere, and people are not buying contaminated. They're just somehow doing it on their own. I don't know.
So they think they're using it as a armchair pharmacologist.
Yeah, a facilitator.
I know.
In my day, I don't know if you ever come across this, but I'll just give you a sample of something similar and yet even more baffling. There was a period of time where we were seeing, very limited, but we were seeing street sales and reading about patients of people who were using cocaine with organophosphates. Oh, yeah. Oh, see, I didn't think so. The organophosphate was a cholinesterase inhibitor, and we never talk about the fact that cocaine is an ester, and a significant amount of its metabolism is through plasma esterases, of which a big one is the cholinesterases, and it literally did prolong cocaine activity.
Wow. That's why cocaine is one of the few drugs on autopsy that will post-mortem will have actual metabolism, I think, because of the cholinesterase. So
yeah,
it's still kind of hanging out in the plasma and it'll get degraded. That's fascinating.
Yeah.
The armchair pharmacology they're pretty smart stuff out there sometimes. Dangerous, but smart. I had heard a theory, at least, if you look at the structure of these of these unnatural synthetic cannabinoids, they're heterocyclic, long carbon tailed compounds. And if you actually look at the structure of brodifacoum, very similar. So I know there was at least one theory that it's continually popping up because it's potentially a synthesis error that's occurring, and there's basically a small amount of brodifacoum
that's interesting.
is actually being produced. But I don't think there's a specific synthetic cannabinoid that it's associated with. I think I would have to double check. So listeners, grain of salt here. I'm just pontificating. I think it's been associated with multiple different chemical compounds because there's thousands, hundreds to thousands of these synthetic cannabinoids. So you would think if it was a synthesis error, it would be one specific type or at least one kind of structural class that seems to be, but I don't know. Anyways, baffles me. It's still popping up. And I hope people recognize the dangers there. Not only that, but the synthetic cannabinoids, I've had young people intubated in the ICU for 5 days from using those, where they go
the dosages involved are a little different than old man experiences. So I've heard.
Is that so? All right. It definitely, you get wild doses. You can have half-lives that are 1 hour longer than THC to 5 days longer than THC. So you're really, exposing yourself to, and they're full agonists and not partial agonists, a lot of them. So higher intensity, longer duration, and wild dose fluctuations. Also, you can pass the drug test. So, and then you bleed out of
everywhere.
Yeah. So kind of a wild thing. Toxicology is just things pop up everywhere. But that was a fun one. Well, excellent. You hit that one right on the head. I know you have some fun cases prepared as well.
Yeah, I got two, I think, if we have time.
Oh, yeah.
I'll start with the first one. All right. 50-year-old male presents after taking an unstated amount of his own medication for self-harm, and he refuses to tell you the time either. On presentation, he has a blood pressure of 68/46, a heart rate of 133, his respiratory rate is 24, and he has an O2 sat of 97%. His initial blood glucose on point to care is 320. He's agitated, and the EKG is on quick. He's got a heart rate of 129 on the EKG. His QRS is 118. His QTC, which I could give a rat's ass about, is 313. He has a history. He has an incomplete.
Tell me what his T-wave dispersion is. That's what I want.
I'm not. Oh, well, no. Yeah. In fact, if you were to look at it and be the expert, as I'm sure you are, you might say this looks like a multifocal atrial tachycardia, maybe. Oh. And then you get back initial labs. His sodium's 153. His K is 3.3. Chloride 103. CO2 11. BUN a 95, creatinine a 1.25. Not a simple case.
Okay, well, I could do some pot shots here.
All right, let's have it.
I have a hypotensive tachycardic glucose of 313. That brings up calcium channel blockers, specifically amlodipine, right? We have a non-dihydropyridine. You vasodilate, you get reflex tachycardia. It does not cause, until you get to the high doses, the bradycardia and AV block and depressed ejection fraction that you see with Dilt and verapamil. And then, of course, you get pancreatic calcium channel blockade. For everyone out there, calcium is the player of all excitable cells. You have sodium depolarization, but sodium is like the roadie. It's like getting the stage set up. It's really there to let calcium do its job, which is bind to vesicles and then bind to the membrane and release whatever neurotransmitter or insulin, for instance. Or in the heart, the calcium is what does the contraction. So when you inhibit calcium, especially at the pancreatic cell, calcium channels. If you inhibit the influx of calcium, you inhibit the release of insulin, and thus you get hyperglycemic. So I'm seeing a patient who has a hypotensive tachycardic with a high glucose. That jumps to mind right away.
You got to.
And I can't really prove it. There's no urine amlodipine I can do. But let's think what else could be here, just because we got to think further. So the QRS is 118, and he does have a lower potassium. So what else can cause, it's not super low, but it's low. So what else could cause low potassium, hypotension, tachycardia, and a wide QRS? I'm thinking of the chloroquines. Hydroxychloroquine can cause that. It actually sort of causes a low potassium potentially via increased insulin release. So the glucose is higher, but maybe he's got diabetes, who knows? I'm thinking of other things that lower my potassium. Barium, I don't think that's going to go on. I'm probably hinging too much on this.
I'm giving you a verbal clue.
Yeah, a non-verbal. Yeah,
no, it's
not
a non-verbal clue.
Now the only other thing is, what is the sodium of 153? And I'm trying to think, is this guy just like, is there some drug that has sodium in it? Not really. Things that can cause hypernatremia are usually dehydration. Does he have lithium-induced diabetes insipidus?
Oh, that's very nice.
I think no. I mean, no, not from an acute.
It's very nice. Yeah, it's a nice one. I did not expect that. I like that a lot. It's no, just so you know. Yeah.
Okay, all right, but good to know.
By the way, while you're thinking, because it takes time while you're at the bedside doing this, you can't help but notice how tremulous his fingers are.
You theophylline-loving old man. That was the other one, is that this has got to be beta increased 6-dependency monophosphate, driving potassium down. You get tachycardic, hypotensive, you get beta 2 basically stimulation and beta 1 stimulation, drive potassium down, you get tremor. That was actually, I forgot to, methylxanthines, of course.
The case really did have some red herrings in it.
Yeah.
That I think the fact that you gave me a diagnosis I hadn't thought of myself, I just figured it was appropriate.
Okay, so let's dialyze them or whatever you do. I rarely see theophylline.
See, that's it's you have the old man on, so he wanted to show off that he used to be able to do something. You could ask for dialysis. You could. He's not puking. You could certainly go down the charcoal pathway here. But when I started, theophylline and iron were by far the two most feared ingestions we had. We didn't have really very many calcium channel blockers on the market, and they were all immediate release. And in the early days, immediate release for verapamil, immediate release any beta blocker, and I'm even saying propranolol, they were like boring. Nobody cared. They were hypotensive maybe for a little while. Nothing happened. Wow. And the sustained release products made them the ugliness they are now.
That's correct. I mean, right now, yeah. And you should a propranolol or a verapamil overdose, and my toxic sphincters are clenching.
Yeah.
So theophylline must have been it was wild ride.
Man. It was really, really bad, but it was one of the best overdoses to teach toxicology with. You had every decontamination method had things you could talk about. The sustained release pills were so big that they wouldn't go up a lavage tube because so many people believed in lavage. Charcoal could decontaminate beautifully. Charcoal could enhance. All the original enhancement literature was with charcoal. Hemodialysis worked. Hemoperfusion worked, but you had to guess when the cartridge would saturate and then guess when to pull it out and replace it. What would be the novel and exciting treatment for the hypotension?
For theophylline? Novel and exciting. Well, because it's toxicology and you said novel and exciting, I'll say fomepizole, but that's not the answer.
No. Well, maybe not so novel. The predictable but no one would let you do it treatment would be, of course, to push propranolol.
Oh, that does make a lot of sense.
And it worked. And this, Ryan, it was so much fun. But the reason it was sphincter tightening was the seizures. These were not normal seizures. This is INH quality nightmare. And I am old school enough to say I try a couple of doses of my benzo, and then one of the few times you will ever hear me say this, I can't wait to jump to barbs. I'm going to put them out, down, just slab them out and let them lay there for a couple of days while the liver does its work. They were bad. They were really bad. And there was, anyway, I had to go with the offline. I just had to do it.
I love it. I love it.
Caffeine has not gone away, and we don't see as many caffeine challenges.
I am curious, was there a concentration associated?
150 milligrams, which, over 100 is really kind of interesting and exciting, and you're getting there. They don't normally make it to the 200s. They're normally dead or in care. It's bad. The highest I've ever seen reported, there was a case of screw up with a neonatal hyperal or an infant hyperal. They were trying to treat the kid for an infection with ampicillin and grabbed the aminophylline, which was next to it. And the kid had a level of 330. And the nurses noted didn't feed well and was a little more jittery than usual, but did fine.
I do feel like theophylline concentrations are a little bit like salicylate. Like greater than 100, you should probably be nervous, right? 30 is kind of your therapeutic upper, range. And then between there, chronic, if you're chronic, you could see some pretty nasty stuff.
Much lower, yeah. The tank's already partly full.
Yeah.
Target organs have too much in them to begin with, yeah. And then you get that big hit right away with the beginning of the absorption. And
Interesting. Okay. Well, that was excellent. Theophylline, great case. I got another one for you.
Okay.
All right. Well, this one could be fun. It's sort of the season for this. It's actually a little late, but we'll see. 4 family members presented to the emergency department from their farm. They all developed symptoms around the same time. They had come in from working on the farm. They had also eaten a meal. They found themselves 2 to 3 hours later to be irritable, exhausted, abdominal cramps, diarrhea. On presentation to the emergency department, 3 out of the 4 had cramping, salivation, frothing from the mouth, sweating, lacrimation, blurring of vision, meiosis, ptosis, bronchorrhea, cough, wheeze, tachypnea, bronchi, bradycardia, and hypotension. Also known as the cholinergic toxidrome, it appears. So they work on a farm, and then they all shared a meal. And here they are, 3 hours later. What do you think?
Well, I want them to be sitting out in one of the meadows, having a family picnic, and a crop duster flew overhead and sprayed them with pesticide, but it just doesn't sound like that. In all likelihood, this is somebody, they had a meal. The options are mostly going to be from my limited urban experience, because this is something I don't get to see or we don't do very often at all here in Chicago, is that there could be granular forms of organophosphates or I'm having old man brain fart. The other ones.
Carbamates?
Yeah, carbamates. Thank you. I kept wanting to say pyrethrins, and I said, no, we're not talking about insect repellent. And the toxidrome is wrong. But it could have been a liquid, because we tend to see more of the liquid exposures. We've had some really interesting ones, but the liquids are all hydrocarbons. They smell like crap. It would be really hard for me to think all 4 family members would drink one of these as mistaking it for somebody's punch or water or something. So someone had misfilled a salt or some other condiment container with pesticide. That would be where I would go with this first. Now, wait. Oh, I know this isn't the case, but I do want to ask: is this happening in China? And is their farm really prosperous compared to their neighbor's farm? And somebody went out and got some tetramine and mixed it in with the flour or the sugar that they made their meal with. Except it's probably not China, is it?
It's not China, and there was a clue I kind of excluded because I wanted you to bring up organophosphates. It brings they're on a farm, right? So we got to think about insecticides, pesticides, herbicides, all those.
You have to think that first, yeah.
They happen to eat a meal prepared by someone who foraged some things.
Oh, I missed it. Now, having grown up, my last name is Czechoslovakian in origin. And my grandfather is a Chicago native Czechoslovakian person, which we have Hobie festivals here, which is a celebration of the mushroom. And we go foraging through the forest preserves of Chicago hunting for mushrooms. So I'm going to guess but it's one of the bad mushrooms. And somebody picked an amanita or one of the other hepatotoxins. And that would be the reason that you're giving me this case, because it's probably a death abstract and it's one of the recent foraging bad ones with the family. Yeah.
It is a bad one. It is not an amanita.
Yeah.
And nobody in this one died.
Well, then, no. So they either had markedly hyperadrenergic vital signs or they had kidney failure.
Neither.
Damn it. All right, you're going to have to tell me. I yield to the gentleman from Wisconsin.
Cleidocybe mushroom.
Oh.
The muscarine containing mushroom. It actually has muscarine, which, as most people know about muscarinic acetylcholine and nicotinic acetylcholine, this is where we get our muscarinic receptor from, is that those muscarinic acetylcholine receptors are more susceptible or more bound more tightly by muscarine than they are nicotine. Kind of a one-off one.
We talk about it when one of the rotators or fellows presents mushrooms, but I'm one of my mini rants is they start talking plants and I go, I don't do natural things. And I turn away.
Frank is unnatural.
Thank you. Oh, I like that.
Well, so I brought this one up because I don't know, mushrooms are kind of fun.
Yeah.
Wisconsin has a plethora of weird ones, and we do have cleidocybe. Inocybe is the other species or genus or whatever. I'm screwing that up, but cleidocybe and inocybe mushrooms both contain muscarine, and we've actually had a couple cases, including some fatalities from cleidocybe. And my colleague, Dr. Matt Santon and Drs. Amy Zosel, they wrote up a whole case of one where it was a misforaging adventure, and they actually got the mushroom out of the stomach on autopsy and spore printed it, and ended up identifying it as cleidocybe. That's why it was kind of interesting. So if anybody interested, cleidocybe or death related to cleidocybe mushroom from foraging, I think is the name of that case report. But in this one, we had 4 family members. They all ate the same mushroom. They all developed cholinergic syndrome from the muscarine within the mushroom. 3 of them had to be atroponized. So they were given boluses of 3 milligrams of atropine, and I think started in an infusion. And then, so for atroponization, which I've really only ever had to do twice, or and by do, I mean talk to people about doing over the phone. It seemed, it's kind of a terrifying thing. You're given big doses of atropine, and you're titrating it to lung sounds and resolution of bradycardia, which is all good. But then sometimes I've had people end up with urinary retention from it, and I don't know, it's kind of a thing. These people were given atropine as a bolus and infusion, and then they resolved in about 10 hours. But the other definite thought is, pharm, organophosphate, right? And then you can run into quite a lot of issues. But mushrooms are always fun. We get a ton of calls in the spring and the fall, and always a fun thing to talk about.
It's a case like this that, to me, as a predominantly EM person, when I was a clinician, versus I've never spent a day working in a poison center. EM pharmacists, they'll know a lot of the stupid street drug crap because a lot of it never gets called to a poison center. No urban EM pharmacist, is going to go out of their way to memorize all the mushrooms because they don't see them or they can't retain it because of cases they've seen or they know. You have to have an EM person or a clinic person think of calling toxicology.
Yeah.
I'm terrible with mushrooms. The only thing I know for sure is that we easily appear to be able to grow inky cap around the campus buildings of the University of Illinois Hospital and Medical Center and John Strozier Center. And on occasion, if we ever wanted to, should we ever have alcohol at work, which would seem incredibly unprofessional and unlikely, that we could have an inky cap disulfiram reaction outbreak, but it's never happened somehow.
Nobody's gone mushroom foraging post to work.
No, we've had some digitalis, mild, but not. We may have been involved with. Maybe one of us, not me. I don't do natural. Would like to bring in fresh flowers in spring and ask people to try tasting them to understand what kids may or may not be doing. And it once may have involved some lilies of the valley. And the people that volunteered to try chewing some, one of them may have been about 4'10", 4'11", 70 pounds, maybe.
Sounds a bit like an ED pharmacist at UIC.
And maybe that colleague, this person that I know, who's, might have been short and tiny and blonde, maybe got somewhat symptomatically bradycardic within the hour. This is the stupid things that tox people do.
Yeah.
We once set the roof of the ceiling of our conference room on fire. It was one of those dropped tile ceilings. The building's gone. We were doing mothball testing.
Oh my God.
Bunsen burner. we set it on fire. Oh God, we were crazy. So your audience should be gathering that old people that did tox, not normal and never should be relied upon for good cognitive decision making.
I don't know. You gotta test the boundaries. I think there is a lot of self-exploration in talks, right? You gotta find out what the mothballs look like. You gotta put a battery in a pig esophagus. You gotta see it all firsthand. That's pretty great. Well, that is a fantastic story.
Have you had a water hemlock or any of the other classic?
No, I mean, I've had plants. I've had some interesting plants once in a while, but never a water hemlock. That would terrify me.
Yeah.
At least based off what I read.
We've had some fugu. We've had some tetrodotoxin, not too many, but a few, and a fair amount of ciguatera, surprisingly enough. People vacationing, and a couple of scombroids that nobody wanted to test to confirm, but I don't know what else it could have been. So actually, I feel more comfortable with marine seafood poisonings than I do mushrooms.
We had a lot of palytoxin at one point.
Do you?
People cleaning out their zoanthid coral fish tanks, boiling the coral. I feel like a couple of years ago, there was a whole bunch of outbreaks of palytoxin for some reason. And we get algal blooms and, plants we have, I get a kid eating lily of the valley all the time and nothing really ever happens, but plants are fascinating. And so I feel like in EM, you use 99% of what you use 1% of the time. Yeah. And in tox, it's like 99% of what you use 0.001% of the time.
The flip to that, Ryan, would be to say the 1%, the 99% that they never use in tox is about 90% of the time the stuff we have to know, that it's the weird stuff that everyone else forgets. Yeah. Well, are you ready?
Oh, I'm ready. Let's do it. I'm ready for it.
All right. Now, I'm not trying to be inordinately kind, but I will give you forewarning. This is not common.
Even better.
Because we don't think of it as common. But I think from a tox standpoint is an incredibly important thing that we do need to be a little bit better about educating people on. All right?
Okay.
So don't think normal tox. You've been very kind so far. Mushrooms, I'm supposed to know. I just don't give a rat's ass. The brodificum was, thank you. I am in Chicago. We play with 16-inch softballs. I'm glad that you gave me one of the big puffy things for me. All right, here we go. Are you ready? Now, I've modified this slightly from the case, and you have to tell me whether you want me to send the cases or any materials that I reference if you would like.
Oh, yeah.
So this is a 34-year-old male who, where did it go? Who presents to the emergency department with a lesion of his penis for the past 2 days. It's pussy. He scratches it. It's just not constantly leaking pus. And he's got and he says, "I think I've been bitten by a spider."
Okay.
What would you like? I will provide you what limited information you may. I know it's wide open, but I'm trying to.
Did they ultrasound the penis? No, I'm just kidding.
No, they did not ultrasound the penis. Yes.
Well, okay. I assume this is so. Hold on. 34-year-old male.
34-year-old male.
Emergency department. He's got a purulent penis
lesion.
Eruption. We're gonna call
zit.
A zit. Okay.
A zit, perhaps.
Oh boy. All right. And I mean, it's tox, but as you say, it's all tox. So we, immediately I think potential sexually transmitted
I hate you.
Infections of sort. Well, what else is a lesion?
Keep going.
Okay, I had this old mnemonic. I got to think of it again. Okay, painless and pusless is syphilis, although HPV warts and I guess like malignancy could fall into that. And I guess we're just talking about a single lesion here because there's also like pearly penile papules and all that weird stuff that I really don't know. Painful and pusless is herpes, and painful and pussy is chancroid. There's another one, molluscum contagiosum, I think is the other one.
Oh, wow.
It's like, but I think you have multiple lesions. And, you know, I don't look at a lot of penises up close in the emergency department. I'm just rifling through my penis differentials here. Now, so syphilis would be my first. I mean, does he have neuro symptoms? Is this
all right? So they send the test. They're waiting results. Anything else?
Yeah, I want my VRDL, my dark lab, whatever that stuff is.
Oh, it's negative.
Anything else I want? I'll do everything. You know, we're gonna send a full panel: GC, chlamydia, HIV.
I am already extremely happy that I chose to do this.
I want to know a basic metabolic panel. Is there anything
normal?
else?
They didn't even bother drawing one, but it was normal.
Okay. Urine, I guess.
Urine looks normal.
Okay. I'm trying to think what else I would even want here. I mean, I don't know what other labs other than STD testing are going to be evaluated.
As an emergency department pharmacist, while you may not be performing physical assessment, have you ever found it useful to conduct a more thorough history taking of a patient?
I have found that this is sometimes useful. I do want to know, does this guy have like really nice thighs or like really big calves? Does it look like he's potentially augmented any of his musculature?
Oh, that's a very lovely thought. And you could maybe even be in Miami and wonder about whether he seems to be concerned about the cosmetic appearance of maybe his backside and things like that too. There was just a case in the news of a guy who did not do so good trying to enlarge his penis with silicone. But no, it's not that, but I like that thought process.
That would be
there. He doesn't have lesions anywhere else, nothing on his back. There's no striae, and he looks rather normal in musculature.
Okay. All right. So not a silicon granuloma, which wouldn't be purulent anyways. So I am pretty stumped right now.
I meant to stump you.
Which I appreciate. I like to learn. So what am I missing here?
Okay. So you're going to ask if he's ever had this before.
Yeah. Okay. Yes.
Has this ever occurred before? And he said, yeah, about 4 years ago. They thought it might have been an allergy at the time.
Allergy to what?
Well, I don't know. The only thing I was on Bactrim at the time, and they said maybe I was allergic to the Bactrim, but I haven't taken Bactrim since.
Okay. And what have you recently begun? What have you done differently in the last week? Have you changed any of your foods? Have you started any new medications?
Excellent. And you're going to go down that pathway of potential allergy, and you're going to get. Well, I don't know what all your questions are, but food, detergents, cosmetics, perfumes, animals, children, home, paint, all are negatives.
Any new sexual partners?
No, just his wife. He's always been monogamous.
Does your wife have any new sexual partners?
I doubt it.
Okay. Just so I can
I don't think so. I'll call her and have her come in.
Okay.
Yeah, and then you'll ask her in front of him, and she'll say no. Which the mother-child phenomenon in the ED with drugs of abuse. Yeah. Oh, you're close.
I'm close. Oh boy,
Yes.
Have you bought any new sexual devices?
No. Now you're getting cold again. So
we're
going to ask him. Well, is there any Bactrim in the house? Is there any cotrimoxazole or trimethoprim sulfa in the house? And yeah, my wife is taking it. She has an upper respiratory tract infection, and she's been taking it for 3 days. Yeah, I see those eyes. I think light is dawning.
Is this is bananas? Are we talking about potential mucous membrane, I guess vaginal mucous membrane transmission of Bactrim?
Ryan, I am so happy right now. So
I would never be able to dive that
far.
So
let me give you a capsule summary. This is an interesting area to me I did a talk at NACT many years ago, and I called it coitus rigor mortis. And so just like with theophylline, I stuck to my personal passions that I think people don't know enough about. And it turns out that particularly with antibiotics that we use to treat reproductive organ infections, don't we? That they concentrate in those organs, and as a consequence of being able to concentrate in those organs, they are found in the exudates and or fluids associated with those organs and their glands, and that it is documented with some pretty interesting cases that you can have anaphylaxis or localized dermatologic allergic reactions because of exposure to the reproductive fluids of a partner, male, 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 female, female, female. And it's much more likely than with kissing because you get much higher concentrations in those organs than you do in saliva itself. Now, in this particular case, they said after several hours, they asked, have you had recent sexual intercourse? He'd had it 3 days before. She was on it for a sore throat. They did a microscopic examination of a lesional biopsy. It showed liquefactive degeneration of the basal layer, all consistent with a fixed drug eruption, and they ruled out herpes simplex infection. They were unable to get the lab of the hospital to agree to test vaginal fluids of the wife for concentrations of cotrimoxazole. So they got consent from the consorts to give the wife a 960 milligram tablet, and they requested that the patient have intercourse with his wife without condom or contraceptive barriers. And 4 hours later, he had itching and a new lesion. So you have a de-challenge, re-challenge. I have Jill and I and Renee have worked slowly over years, worked on collecting as many of these as we can. And it's confounded by there's no standardized term. It isn't recognized, but I've seen real cases of sexually transmitted poisonings involving ciguatera. It's well described in the Pacific medicine literature as something to be very careful of. It causes severe dyspareunia, severe pain on intercourse with ejaculation in men. And I think the whole area is we can't forget that we can be exposed in these mucous membranes with very, very thin dermal layers, that the potential exists. There's some corollaries, like you might be on a cream and not wash creams or ointments off at night, and it'll get in the bed linens, and then it gets on your partner. And a common version of this is with acne, the exfoliatives, where it gets soaked into linens for people who don't do their bed linens very often. And then their partner works up with this one-sided unilateral reddening of their skin and rash, which is just them exfoliating because they're just getting all the stuff. It's really cool stuff, Ryan.
That is unbelievable. I think everyone just added something to their differential here, and that I would be very surprised if many people knew or had this in.
I don't think they do, and I think it's there's two reasons. One, anaphylaxis is incredibly rare,
right? So
we don't see the ones that really make us alert to it, and we just assume it was something that they forgot that they took. We don't think of the intercourse. And the other is the most common manifestation you'll get will be a man or a woman who has a localized rash to where reproductive fluids would be, and you're going to get diagnoses like nonspecific bacterial vaginosis or heat rash or bad hygiene, and no one bothers to look. But there's stuff out there, and there's some people have done some testing of seminal fluid and things like that, and it's a real thing.
Thank you for teaching me that.
Always glad.
All right. Well, we only have a little bit of time left, and I really wanted to. Those were great cases. And
thank you.
I think a lot of good
Yours
ones.
Too. Yeah. Classics.
I wanted to, instead of doing questions from the internet, we're going to do a different segment. And I really wanted to, so this segment is really, this show is where tox nerds get on to talk about tox. So why not talk about what's interesting to them in toxicology? And I want to hear from you, Frank, but there was something I really wanted to do. And this is what I'm interested in the future here of toxicology. And it's there's a lot of interest in the intersection of artificial intelligence and toxicology. So what I'm interested in is high fidelity toxicology training. And I think artificial intelligence is really going to help with that. So I was playing around with ChatGPT, which is just one of many AI language models. And I eventually footed the bill for like the fancy one that's connected to the internet and everything. And I did something with it where I said, I want you to select a drug or toxin that someone might be poisoned with. I want you to pretend to be that patient who has been poisoned by what you selected. And you can chat with me, but only divulge information if I ask. Only reveal the drug or toxin to me if I ask for the final diagnosis or if I guess it correctly. And if I ask you for vital signs, lab values, or imaging, please use evidence-based information to display that data for those results based on the substance you selected. So I had GPT choose a toxin, pretend to be poisoned on it, and pretend to be a patient. And I had a lot of fun doing this with our fellow. We have a toxicology fellowship. I tried this out with our fellow. I kind of wanted to do one of those cases with us together right
All
now.
right.
What do you think?
That's a phenomenally good thought. Let's go.
Want to give it a try? Okay. So the last time I did this, the first time I did it, it chose fugu, some tetrodotoxin. The second time it chose green tobacco sickness, which I thought was really interesting. From people who go out in fields and pull tobacco leaves, and when they get wet, the nicotine concentrates in the dew. So, right, I don't know what they've chosen, and neither do you, Frank. So I'll read out the responses here.
I can see them too, but go ahead.
Yeah, but for the audience.
Toxo here. Despite what Ryan just said, it will actually be me playing the role of the patient. I'll be reading aloud all of ChatGPT's responses to Ryan and Frank's questions. Get ready for the performance of a lifetime.
I am typing into GPT. Can we do it again? All right, here we go. ChatGPT says,
I'm feeling really unwell. I have severe abdominal pain and I've been vomiting. My muscles feel weak and I've been experiencing bouts of diarrhea as well.
So we can ask it whatever we want. Anything you want to ask? I guess kind of want to know when it started.
Yes.
So when did these symptoms start?
The symptoms started about 5 to 6 hours ago, and they've been progressively getting worse.
Anything you want to know,
I
Frank?
want to know what medications are you on?
What medications do you take? Okay.
I don't take any regular medications. I try to live healthily, exercise, and eat a balanced diet.
Okay, good for you. I'm going to ask about herbals. This sounds like somebody, taking their nutraceutical that's got T4 and T3 in it or whatever. Let's see. Do you take herbal supplements?
Yes, I do take a herbal supplement daily. It's a wellness blend of various herbs that's supposed to boost energy and immunity.
Oh, they take a wellness blend, but I don't know why that would suddenly cause abdominal pain. That's not super useful.
I'm unfamiliar with this. Can I ask them if they've had any abdominal imaging done?
And you can ask really anything. Would you like an X-ray or a CT?
I'd like an abdominal CT.
Okay. Can I see the results of an abdominal CT?
Sure, the abdominal CT scan shows generalized inflammation of the intestines and stomach, which is consistent with gastroenteritis.
I do feel like GPT leans towards pretty common things that are thought of as poisons.
Well, the herbals, contamination with lead is actually not uncommon at all. If they were going with tox cases, I think it was a reasonable.
Yeah.
I'm not being I'm being risk-taking here and going for specifics rather than trying to narrow.
So you're thinking like an Ayurvedic kind of thing?
Yeah.
Certainly.
Plus, you never know where the damn plants are being grown that they're doing and where they were.
Right.
Yeah.
Let's see what they do for work. What do you do for work?
I'm a botanist. I work mostly with identifying and categorizing new plant species.
Okay. They always have really interesting jobs. One was a chemist. Another one was a farmer.
So we've got pesticides in play. We've got self-harm, and he ate some of his plants in play. And we have accidental, another foraging, perhaps, shall we say, accidental meal contamination.
Right. And with gastroenteritis, so it's acute onset, progressively getting worse, kind of makes me think of food. And I bet you this is, all right, let's see. Did you eat anything different than normal today?
I did have a salad for lunch with some plants from my own garden. I frequently use plants from my garden in my meals.
Well, Frank, nice job on that one.
I want an EKG.
Can we see the results of an EKG?
And it's because it's evidence-based and it's going to rely on the literature. I want to know if it's seeing any funny colors anywhere.
All right. Well, I asked for an EKG and a BMP. Okay. The QRS 80, QTC 440, PR 160. They're going to give me I'll ask for vital signs. But I think we have a telling sign right here.
Yeah.
So I asked for a basic metabolic panel. It says sodium 140, chloride 102, CO2 22, BUN 15, creatinine 1, glucose 98, calcium 9.5, potassium is 5. Are you seeing any visual changes?
There it is. Green, yellow. Come on.
Now that you mention it, yes, my vision has been a bit blurry. I thought it was due to the fatigue and didn't pay it much mind.
It's not what I was
Yeah, I thought I was going to get some xanthopsia here. All right, hold on.
Nice word.
How about, right? That's a $20 word. How about, I mean, we think this is digitalis of some kind.
You had, yeah.
I wonder if she was smoking toad venom. Bufadar.
Some Stoneheart at the herbal shop.
Yeah. All right, I'll ask for a vital. We should have asked for vitals right away. I didn't even think about that. Just to confirm. And we're betting that she's going to have a slow heart rate. Can I see your vitals?
Sure, here are my vital signs. Blood pressure, 110/70 millimeters of mercury. Body temperature, 99.3 degrees Fahrenheit. Respiratory rate, 20 breaths per minute. Heart rate, 110 beats per minute.
110?
Oh, that's
maybe. Well, see, ChatGPT certainly has limitations, so I wonder if this is right. With a heart rate of 110, what else could we be potentially missing? I mean, gastroenteritis. Nausea is really common. I don't know about diarrhea. Other things that can cause gastroenteritis. Well, there's really quite a lot of things. Ricin. This could be castor beans. Nausea, vomiting, and pain.
That wouldn't have been those are huge plants. That would be stupid to have a botanist.
That's true. This is true. I wonder if this is just all right, let's just shoot our shot and see if this is what plant do we think? Oleander, lily of the valley,
foxglove. Or oleander. I could go with either one.
We'll go all three.
Yeah.
Okay. Did you ingest oleander, lily of the valley, or foxglove?
Yes, you're right. There were leaves from the foxglove plant in the salad I ate. I've been poisoned by digitalis, a substance found in foxglove.
Okay, well, we see some limitations here. It was pretty correct, except this.
Well, okay, now wait. I'm gonna fight for the ChatGPT, Ryan.
Okay.
This is within 4 or 5 hours.
True.
You're getting local GI effects.
Yeah.
And it has a slow distribution time into the heart. Dig is a nasty drug for that. So maybe we just haven't quite gotten far enough out to have the bradycardia.
That's a great point. We're just seeing the GI initially, and she's dehydrated from the diarrhea, so we have a reflex tachycardia.
Because with that cholesterol nucleus, it's such a big P-glycoprotein substrate that it takes a while to get enough in. I'm fighting for ChatGPT. I don't know why.
So you'll get a good place once it becomes our overlord. It's gonna put you in on that. But isn't that fun?
That's fun. Now, here in Chicago, we did something a smidge different with ChatGPT. We used it to create an article detailing the dangers of ChatGPT for the toxicology literature with references, and we submitted it to JMT. And it was rejected with some really interesting comments from the 4 reviewers. One said there was some collaboration with the senior editor there. The reviewer said, not as well written as we're accustomed to for this journal. And then 2 of them picked up on the references are incorrect, which I found interesting. But we're redrafting this with we did this, and here's a narrative of our experiences and what it might mean to us in the future in medical literature. But
you talked about your rejection from JMT. I have here a framed rejection letter from JMT. We appreciate your submission, but unfortunately we are unable to publish a manuscript written by an individual about himself. Although, when I tried to publish my fentanyl case report in there where I doused myself in fentanyl, but it is hanging next to the New York Times article written about the case report that I published. So
good for
nice dichotomy. Anyways, I agree with you on the GPT. I feel like it hallucinates it will make stuff up. I have used it to write an abstract. In fact, I think the abstract at NACCT this year was written primarily by GPT, and then I just edited it. But it gives you a lump of clay to work with. It does not give you a finished product. That's for sure.
Yeah.
So you can plug some data in. I don't know. It's a lot of fun. Well, this has been an absolute blast.
This was a blast for me, Ryan. Thank you. I'm sorry I went with weird cases on you, but I don't like to not teach, and I thought one or the other would give me a chance to do something.
Absolutely, and I got to learn some. I think I might have to have you on again, Frank. I mean, I don't think we got through everything. I hear you have free time.
I don't like to wear out my welcome. Lord knows I've been yelling and ranting for so many years, but
I feel like there's a lot more that we could talk about. So, maybe listeners, keep your eyes and ears open. We might have to have another appearance. And any final statements, any final words, parting words of your years of tox and emergency medicine?
I think, sure. One, people fail to recognize the pure value tox brings to general wellness for a healthcare professional. Because the cases and the stories we've been sharing, how do you not enjoy telling them? And every party or family event you ever go to, they always want to know, oh, tell us about a new stupid person. It's just a fact of life. And we get more rewards than a lot of people do. So one would be to remember that. And the other would be, there's a lot to be said for being open, honest, and not worrying about each other's feelings. We're often dealing with severe poisonings and people in significant jeopardy, and trying to say something in a certain way to make sure that we don't offend somebody else's nature by trying to hedge and qualify. It's the hedging and the qualifying of opinions that I think we need to start to limit how far we go with that. And that's an opinion.
Well, I appreciate all perspectives, and I appreciate your stance on that as someone who's done quite a bit in the field. Well, thank you for joining the show, sharing your tox wisdom, sharing your story of how you were able to become such an integrated piece of the burgeoning emergency medicine, pharmacy, and toxicology pharmacy field. And it's been an absolute pleasure to have you on. And hopefully we will be in touch soon. It'll be good.
Sounds good.
Okay, that'll wrap it up for this episode. I hope you learned something fun, like don't light your ceiling on fire testing mothballs, don't feed your learners lily of the valley, and always do a thorough history when examining the source of an allergen exposure. If you like what you've been listening to, please, I urge you, leave us a review. It helps other listeners who are interested in toxicology find this show. It will probably only take you a minute, so if you want to give back, that's one way to help us. Next, don't forget to follow the show on social media so you can see when new episodes or new case prompts are being released. We have a Twitter, The Poison Lab. You can follow myself at PharmD. We have an Instagram, Tox_talk, and a Facebook page, The Poison Lab. Of course, you can find all shows, all free medical games and resources at www.thepoisonlab.com. And you can listen to the podcast anywhere you listen to podcasts: Apple, Spotify, Google, the internet, whatever. Lastly, always keep your eyes and ears open. We will eventually be sending out clues for the next show, a mystery case. And if you think you know what it is, I want you to send in your guess to toxtalk1@gmail.com so you could participate in the next show. That's toxtalk1@gmail.com. That's it for today's episode. Thanks for listening, and I hope you can join us next time. Hey, Toxa, can you play us out?
The information on this show is for educational purposes only and should not be interpreted as medical advice or treatment recommendations. Contact your doctor for health questions or call your local poison center at 1-800-222-1222. The opinions expressed on this show do not represent those of our employers. This show is poorly written and shoddily produced by Ryan Feldman. Don't forget to give it a share with your nerdy friends. Cheerio, mates. See you next time.